Hi, I'm Dr. Jared Gardner, and I'm here today with the awesome dermatology and pathology residents from University of Massachusetts, as well as a DermPath fellow and several other awesome people who we're going to sit down together tonight and talk about one of my, I have to admit, least favorite topics, cutaneous hematopathology. So we're not going to go way out into the weeds, but we're going to talk about some basic classic things at my level as a non-hematopathologist. And then I am very lucky that I get to have colleagues who really love skin lymphomas and heme things that I show stuff to. And I often consult my colleagues on difficult Hemepath cases, and I learn so much from them. The thing I learned the most is how much there still is that I do not know about cutaneous Hemepath. So I'm really lucky. Currently, I work with Dr. Jackie Junkins Hopkins, who is a skin lymphoma guru and is always like, "Oh, here, I'll handle that case. Don't worry." So I told her I'm always happy to trade for spindle cell cases, but I think she helps me out way more than I help her out. So in any case, let's talk about some of the basics, and we'll go through this. Feel free to interrupt and ask any questions that you may have. All right. So and also, this is a project I recently completed. It took me a while, but I went through all of my videos and a lot of my digital slides and posts, and I organized them into two complete libraries organized by entity name. So it makes it easier, hopefully, for people to find what content I have about individual topics. So I have one for DermPath and one for bone and soft tissue tumors, and that includes DermPath mesenchymal things that occur in the skin, like dermatofibromas and lipomas and angiosarcoma, is all going to be in the bone and soft tissue part of it. That's how I organize my slide collection, because it helps me to keep straight what is what. So anyway, hopefully you'll find that useful, and I will continue to add to those posts over time. So it'll and I'm working on currently releasing more and more sample pathology reports that give examples of the language I use when I sign out cases and how I hedge when I have difficult cases, stuff like that, in the hopes that that'll help people learn how to do that better in their practice. And also, again, talking about Hemepath colleagues, this is a book by Antonio Subtil, which is Diagnosis of Cutaneous Lymphoid Infiltrates. It is a fantastic, awesome cutaneous Hemepath book. If you really want to learn more about this, that is a great place to start. It's it's full of awesome pictures. And if you want to see what it looks like inside, I've got a video textbook review down there. I'm not paid any money to promote this. I just think it's such a great book. And I heard Antonio Subtil speak at a meeting a couple years ago, and I was blown away by how well he explained things in such understandable visual terms. And he said, "Oh, I've got a book coming out." And I was like, "Please send me a copy." And so they did, and I was happy to promote that online. Because I would love to help other people find some clarity in this really complex topic. Okay, so first let's talk about mycosis fungoides, right? This is probably where we should start when we talk about skin lymphomas, because MF is a relatively common skin lymphoma as skin lymphomas go. And it's a thing that we encounter, that all of you probably have seen patients with it, and if not, you will. And also, it's a thing that we're often thinking, well, is it MF or is it not MF? And that's really challenging and something I still struggle with on a regular basis, and I think everyone does, honestly. So let's look at some classic examples of what we want to see in mycosis fungoides. This is a really slam dunk example. And what we look at is mycosis fungoides is a T-cell lymphoma. There are other types of T-cell lymphomas in the skin, but MF is, again, probably the most well-known and most common form. And what happens is that the clonal T lymphocytes, they infiltrate the epidermis, and that's called epidermotropism. And that takes several forms. One of the forms is this, what we can call tagging. The atypical lymphocytes, they're hyperchromatic and a little bit enlarged here, but they don't always look that way. Sometimes I feel that mycosis fungoides has relatively small, bland lymphocytes. And if you find it difficult to evaluate lymphocyte atypia, you're in good company, because I think unless they're super ugly, I find it really challenging personally to evaluate the atypia. And if you're looking for, cerebriform crinkled nuclei, man, I promise you, I can find some cerebriform nuclei in any skin. Give me a biopsy with some lymphocytes on it, and I'll find you something that looks cerebriform. So I think it's something that is it's a skill much beyond my ability personally. But what I go on more personally is the architecture usually. And then you combine that, of course, very importantly with the clinical. So I'm not really going to show clinical in this lecture, but that is so crucial, is making sure that if I think something looks like mycosis fungoides, it really has to fit and make sense clinically and fit with the history and the appearance. And so that's why it's often really difficult to make a definitive diagnosis of mycosis fungoides if you don't have a complete story, that especially with the dermatologist's impression and the clinical information. So anyway, back to what we're seeing here is we've got the lymphocytes and they're tagging, they're scattered along right along the basal layer of the epidermis here. When they do this, they tend to get little vacuoles around them. Sometimes we call those halos. And so this tagging of lymphocytes with halos around them along the basal layer is really helpful. Well, you might say, if you're savvy at DermPath, and you're like, hey, that looks kind of like vacuolar interface dermatitis. You're right, it kind of does. And in fact, there are plenty of times where I think, ooh, is that vacuolar interface or is that epidermotropism? Well, one thing that really helps me is that mycosis fungoides usually has a lot of lymphocytes, but not much reactive response from the epidermis. So not much spongiosis and not many dying keratinocytes. There are exceptions on both of those things, but in general, when I see too much for too little, too much lymphocytic infiltrate and too little inflammatory response like spongiosis or dying keratinocytes, that's when I start suspecting mycosis fungoides. The other thing you're going to see is this wiry, thickened collagen. And the collagen patterns of the dermis, I think, is a little bit more subtle skill that takes a little while to be able to pick up on. But next time you look at a piece of normal skin, go look at the papillary dermis and look how fine and delicate the collagen is compared to the thick, more chunky bundles of collagen in the reticular dermis. Here, there's no fine collagen. This is dense, wiry collagen that's replacing the papillary dermis. This is a sign of chronicity. This process has been going on for a while. Now, the problem is that other things like chronic spongiotic dermatitis will get fibrotic like this too. And in fact, when I put a biopsy down that looks like chronic sponge derm and I see this fibrosis, right away I know the dermatologist probably has mycosis fungoides on their differential diagnosis, because the things that make it look chronic microscopically are going to make it look kind of like MF clinically too. So again, this is part of the problem, that it can be challenging both clinically and microscopically to sort this out with certainty. And I see a little box popping up. I'm not sure if it's a chat, but if you guys have any questions, you can just interrupt me. If you're waiting for a gap in my speaking, it's never going to happen. So you just interrupt me and I will answer your question and then we'll go back to it. Don't worry. So anyway, the wiry collagen is a helpful sign. The lymphocytes in the epidermis, the tagging, all of that are useful features, okay? So that's mycosis fungoides. And there's the tagging highlighted by CD3, which is a marker of T cells. Basically, all normal T cells should be CD3 positive, and most T cell lymphomas are going to be CD3 positive. So that you can see they're just like, completely replacing that basal layer with lymphocytes, okay? Now, here's a more exuberant example. This was probably either like the plaque stage or even tumor stage mycosis fungoides. Even though those are clinical terms, they do correspond with what we see microscopically. And the reason I'm showing you this one is, in addition to the real dense infiltrate down in the dermis, look what's happening up here. We have clusters of atypical lymphocytes making these little pockets in the epidermis. And so those are the classic Poirier microabscess. Now, you don't always see those in mycosis fungoides. And interestingly, if you ignore those, look, there's actually not much tagging. So each case is a little bit different, Sometimes you have tagging, sometimes you have Poirier, sometimes you have both. Sometimes, particularly if the patient's been putting, steroids on it, or maybe they've had, ultraviolet light exposure, sometimes you lose all of the epidermotropism. And those cases can be really, really difficult. So in any case here, these are the Poirier microabscesses. And when you look closer, look, you can see they're a nice collection here. Now, you know what that looks like? Those look an awful lot like Langerhans cells to me. And remember that Langerhans cells like to aggregate together and make these kind of pools or nests in the epidermis. In spongiotic dermatitis, particularly like, contact dermatitis, we often see that, but other forms of sponge derm also. So the big distinction is, if I see something that I think, ooh, I'm not sure if those are Langerhans cells or T cells, immunostains will easily solve that for you. If those are Langerhans cells, no problem. That could just be, it's probably just reactive. If, on the other hand, those are T cells, then this is almost certainly going to be mycosis fungoides, or there are some other forms of lymphoma that can be epidermotropic. So we're not going to go delve into that in this talk because it is complex. But I do recommend you look. And again, that book I talked about at the beginning that Dr. Subtil wrote has really nice tables in there. Here's all the lymphomas that can be epidermotropic, and here's all the ones that can have CD56 expression. It's really quite useful. So in any case, those are Patriae microabscesses. And here is just from a different case, but you can see on this CD3 stain, these are definitely not Langerhans cells, which would be CD3 negative, CD1A positive. These are actually T cells. So I often, when I'm trying to work up for MF with immunostains, I often include not only a CD4 and a CD8, because as some of you probably know, most cases of mycosis fungoides tend to be CD4 positive, CD8 negative. That's not always true. There is a CD8 positive form, and occasionally you can even get like double loss and weird stuff like that. But I don't just do 4 and 8, and the big reason why is, guess what? Langerhans cells and other cells that are of monocyte or macrophage origin or lineage, they express CD4. Antigen-presenting cells tend to express CD4, including Langerhans cells. So if you do a CD4 alone, you're going to see a lot of stuff in the epidermis on sponge derm or on anything, and those are Langerhans cells. So what I want to do is a 3 plus a 4 and an 8, and my 4 plus my 8 should match up and explain all the cells I see on CD3. If I've got a population of cells that's highlighting with neither 4 or 8, that's abnormal, right? If their T cells should have either 4 or 8. You shouldn't be double positive, they shouldn't be double negative, and if they're all 4 or all 8, that's abnormal too. Okay, so the interpretation of those stains is quite challenging, as we'll talk about in a minute, but that's the general basic principle to start out with thinking about. And then again, the nuances are way over my head. Okay, so those are Patriae microabscesses. And here's another case where you can just see really striking epidermotropism. Not only do we have Patriae microabscess, but lots and lots of lymphocytes trickling all the way up into the epidermis here. And these have a bit more cytoplasm than you would normally expect in lymphocytes, which can be confusing because you could look at those and think, are those melanocytes? Are they Langerhans cells? And again, immunostains will solve that. But I have seen cases occasionally where it can be, can trick you at first glance, especially when you're starting out. Now, this is a case of tumor stage mycosis fungoides, and it oftentimes, at least in my experience, I've often seen cases of tumor MF that lacked epidermotropism, at least on the portion that I had on the biopsy. So you certainly can have it, but don't be surprised to see a case where it's just a sheet of lymphocytes filling the dermis and no epidermotropism at all. That happens. Now, in those cases, I could not look at this biopsy here without any information. I can look at this and say this is almost certainly going to be a lymphoma or some other round blue cell thing, even from low power. That's abnormal. The dermis is completely wiped out with just a little bit of collagen left, and it's just filled with blue cells, right? And normally this kind of sheet-like filling goes very well for lymphoma, but I can't really go beyond that here because even from here I don't see much. You can see a real nice clean line between the epidermis and the dermis, so that there's not really any epidermotropism here. So without the history of, oh, this patient has known MF and now they've developed nodules, or without some other biopsies showing me that, there'd be no way I would know just from this biopsy that it's MF. I could say it's probably lymphoma, but that would even with stains I could say it's a T-cell lymphoma, but I wouldn't be sure it's MF unless I knew the patient had patches and plaques that are pigmented and present for years on the double sun-covered areas like the buttock and the trunks, the other way around, buttocks and the trunk. And then I'm like, oh, this is probably MF. So again, a lot of times on a biopsy, I'll say, well, we have to correlate with what the clinical is. So this is why it's so incredibly important to include the appropriate clinical history in your notes and photographs. Hopefully you guys all know this, but a photograph is worth like 10,000 words. And for me as a pathologist, I can't tell you how many times I've started to write down my report and think I know what's going on from looking at the slide, and then I see the clinical photo and I'm just like, delete. There's no way it's that. It just doesn't make sense based on that clinical photo. And snapping a couple pics and putting it into the chart is so much faster than writing multiple paragraphs on the requisition sheet. Although I'm fine if you want to do that too. The more history, the better. But definitely you can really help with good clinical photos can make a huge difference. Okay, so I've harped on that enough. Now, this is the picture we started at the beginning, and wow, look, immunostains are so great, right? It's easy, right? CD3 positive, so it's T cells, and in this section, actually, you can see some Patriae microabscesses. Look at that. There are a few there. And they're 100% CD4 positive. There's like only a couple little CD8 positive, which are probably just the background non-neoplastic, non-clonal T cells, like the patient's normal background T cells. And then and you can see those same cells are positive on the 5 and the 7. So those few are the normal, and everything else shows complete CD4. So that's way outside of the normal ratio or range of 4 to 8. And then, which I think is normally around like 4 to 1 ish. It's not a hard, fast rule, and I think different people have kind of different views about that. And then look, CD5, which is normally positive in normal T cells, completely lost. CD7, which is positive in normal T cells, although sometimes it gets diminished in reactive processes, totally wiped out. So it's great. This confirms this is a T cell lymphoma that's CD4 positive. But the problem is this worked perfectly here, but I already told you on H&E on that last slide, I know right away this is going to be lymphoma. I guess it could be leukemia or something else. But I mean right away, if those are lymphocytes, it's lymphoma. I mean, almost certainly to my eye. I mean, I guess they're very, very rarely could a reactive thing look like that. I don't think I've ever seen reactive lymphocytic thing that dense personally. I'm sure some Hemepath experts have, but so the thing about the immunostains is they're great in theory, and they tend to work the best on cases that are very dramatic and obvious, like big tumor stage processes. The more subtle and early a case is, the more difficult the immunostains are to interpret, and the less useful they tend to be, which is really frustrating. The times that we need the stains the most, they tend to work the worst. And the same is true, I would say, of PCR to do T cell receptor gene rearrangement. If it's clonal, that can be helpful to support MF, but the problem is reactive things can be clonal sometimes, and occasionally, particularly on really sparse early infiltrates where there's very few T cells present, you can get false negatives because there's just not enough cells present. So again, the really early subtle cases, oftentimes hard to diagnose. Once you got this big tumor, well, yeah, but do I really need to do a PCR here? No. I mean, that's obviously, to me, just on this immunostains, clearly this is T cell lymphoma. I don't see, as not a Hemepath expert, I don't see any way this could be anything else. So that's been the frustrations in practice. So I think some things that I've thought about from what I've picked up over the years is, the early subtle cases, it's very common for early subtle MF to get misdiagnosed, not even once, but several times on biopsy as, non-specific, infiltrate or mild sponge derm or chronic sponge derm. And that's a really normal thing. And that's nothing to do with the skill of the person looking at the biopsy usually. It's just the fact that it's really difficult in early cases. And I volunteer a bit in a patient, Mycosis fungoides patient group on Facebook. And from time to time, I'll answer some questions there, but I mostly kind of observe. But I've mentioned there before to them that this is really normal, and that oftentimes patients require several biopsies over years to definitively establish a diagnosis of Mycosis fungoides. So when I see a biopsy that I'm pretty sure is just chronic sponge derm, but they're clinically concerned for MF, and there's a little bit of some, a couple cells in the epidermis. A lot of times I'll say, I don't favor MF on this biopsy, but I would recommend follow-up. And if this process persists, then repeat biopsies over time may be helpful to further evaluate for that. So I really do think that's important. And that's important if you have MF in your suspicion, to help the patients understand that, on this biopsy, we think it's probably just an inflammatory eruption, but, sometimes MF can look like that. So we want to keep an eye on you and keep following you. We may need to biopsy you again over time if this doesn't get better. Let's just see. So there you go. So let's talk about a little bit of variation. So here's another one where you've got a dense infiltrate in the dermis. But look, there's also infiltrate around the eccrine coils down here. And up here, there's a Patria microabscess. There's another one. This is the area I showed you a couple slides back. But look what's happening. This follicle is totally expanded. This hair follicle is expanded by lymphocytes. And you can see closer there. There's basically like Patria microabscesses and tagging in the epithelium of the follicle. So this is called folliculotropic mycosis fungoides. Some patients have this just in the follicles without any of the epidermal involvement. Sometimes you have both, like in this particular case. And this form can be harder to treat, and I believe some studies at least have shown that it can have a more aggressive clinical course, and it's probably part of why it's more difficult. It's deeper down, right? So a lot of the topical things we apply are going to have a harder time reaching down to those follicles. All right, and here's another case of folliculotropic MF, and this one came with expansion of the follicles, and they're filled with blue mucin, and so this is called follicular mucinosis, which oftentimes, but not always, it goes along with mycosis fungoides, either regular MF or folliculotropic MF, and sometimes you can have follicular mucinosis without mycosis fungoides, either as a reactive phenomenon or an idiopathic finding. I think there's a little controversy. Not everyone agrees with that. Some people believe that all follicular mucinosis is MF, but I'm not. I personally, I think that there are some cases that don't seem to ever go on to progress to MF or behave like MF. So it seems to me like some cases are actually just mucinosis. Distinguishing when there's a dense infiltrate of lymphocytes getting into the follicle, then it's relatively easy to say, oh, it's MF. But the problem is that sometimes you can have lymphocytes with follicular mucinosis. Sometimes you can have clonality in follicular mucinosis. So the distinction in some cases between whether it's just mucinosis or mucinosis plus MF can actually be pretty challenging. So, and I've been told that there's actually some forms of LYP that can kind of mimic this folliculotropic MF pattern. I don't believe I've seen one of those yet in practice, but LYP is lymphomatoid papulosis, we'll talk about in a little bit. And if you haven't paid attention, there's a growing list of things that seem to be weird variants of lymphomatoid papulosis that are there to vex and confuse pathologists. And there's a closer look up at the follicular mucinosis. Now, let's talk about CD30 positive T-cell lymphoproliferative disorder. And I know that sounds like a made-up name, but that's actually what we're supposed to call this by the most recent WHO. But this sounds like a made-up descriptive term that someone, invented last Tuesday. But actually, this is the name that we use to encompass a group of things that can look basically identical microscopically and really require more information from the clinical perspective usually, and from additional workup to be able to sort them out, okay? So here's case one. The patient has multiple red papules, kind of juicy and edematous, and they come and go over time. They're waxing and waning. You guys know as dermatology residents, this is the classic buzzword description, right, for lymphomatoid papulosis, these crops of papules that come and go over time, right? So microscopically, what we see is an infiltrate. There's a little spongiosis with this one, but there's basically an infiltrate that's in the superficial dermis, kind of goes away as you get deeper down. If you have a good imagination, you could imagine it's wedge-shaped or upside-down triangle-shaped, if you have a really good imagination. But basically, it's top-heavy, right? It's an infiltrate at the top of the dermis and not as much in the deep dermis. And then we have here, as we go in closer, you can see there's a mixture of cells here, cells with abundant cytoplasm. When I see cells that are kind of big and have a lot of cytoplasm, the first thing that crosses my mind is maybe they're histiocytes. But other things that can make big cells with a bunch of cytoplasm in the dermis are CD30 positive lymphoproliferative cells, okay? Or reactive cells sometimes too. Reactive lymphocytes too can kind of look like this. So here we do have these large cells that kind of look like histiocytes a little bit. They're got some atypical big nuclei, prominent nucleoli in some of these. There's also scattered lymphocytes around in here too, which is commonly the case. And then there can be a mixture of other cells, small lymphocytes, sometimes even neutrophils mixed in here, okay? But the thing what we're seeing is a scattered large cells plus a mixed inflammatory background, often with the eosinophils. That's classic for. And then here, CD30 is going to be positive in these big cells. I don't think I have a picture. I can't remember. But these big cells will be positive for CD30. So when you put all that together with the clinical history, this is lymphomatoid papulosis. And if you like some people like to subtype it by letter. But again, it started with like A, B, and C. And now it's like D, E, F. I mean, we'll get to Z eventually and then start using like Greek letters, I think, because there's so much alphabet soup. But I mean, the point of these is that these are not so much important for the clinician, the treating physician, but they're more important that these are all variants of the same kind of disease that look very different microscopically. So I always like to say we split diagnoses into different subtypes for three reasons in medicine, or in pathology at least. Number one, and the most important, is that there's a difference in patient care, either in prognosis of how the patient's likely to do, or treatment, how the patient's going to get treated, whether surgically or with chemotherapy or something else. So we split things, and the most important reason to split things out is because it's going to change the way the patient is treated or the patient outcome. Number two is we split things because there's a difference in the microscopic pattern, and we make a point of saying, oh, this is this weird subtype of entity X, to make sure the pathologist remembers, oh yeah, this one looks different, but is actually the same thing, right? And so that's kind of where we are. in my thinking, with lymphomatoid papulosis. A lot of different patterns microscopically that all are similar in the way that they're treated and the way they behave clinically, okay? And the third reason we split is because people and academics have to get published, okay? So you write about a new entity and then you write a paper about it. And I'm kind of joking, but I'm also kind of telling the truth. And you guys hopefully are laughing a little bit at home, and it's funny because there's some truth in it, all right? And hey, I'm guilty too, all right? So this would be the lymphomatoid papulosis type A, which is when you have scattered CD30 positive cells. Now, the problem with this is that on biopsy only, like this case is pretty good. It's got some big atypical cells. But anytime I get a kind of dense lymphoid infiltrate, if I do a CD30, I'm going to find some scattered larger CD30 positive cells. Well, what do I do with that? The thing is that immunoblasts, which is the fancy word for reactive lymphocytes, reactive B cells or T cells, they usually stain positive for CD30. They're kind of activated T cells. And so this is what my Hemepath expert friends have told me. So the thing is that a lot of inflammatory reactive processes have scattered in large cells that are CD30 positive. So when I see that, and I don't feel like there are like too many of them or that they're clustered together, or the clinical doesn't really make sense, I just put it in my microscopic description that, that there are some scattered CD30 positive cells that I favor to be reactive lymphocytes, and that I think that the number of those is normal for the density of this inflammatory infiltrate, okay? But if I have some suspicion, sometimes I'll put in there, I think this is reactive, but you know, lymphomatoid papulosis would be a possibility in the right clinical setting, because maybe this is just the first onset and they don't have waxing and waning papules yet because they just presented recently. And maybe if you follow them over 6 months or a year, you'll say, oh wow, they do have the waxing and waning course, and maybe this is just LYP. So sometimes if I see it and I'm thinking about it, I'll bring it up in my comment so the dermatologist just knows to keep an eye on the patient and see how the process goes over time. Lots of other things have big CD30 positive reactive lymphocytes, including arthropod bite reactions and various other reactive processes. Scabies, scabies can totally mimic lymphoma. It can get so revved up and crazy. I've had one where we were actually doing the immunohistochemical stains, and I think it was actually on the CD30 positive immunostain slide. Guess what we saw? The scabies mite on the surface. So it popped up when we did the immunostains, and we were like, it was just that. So in any case, there's lots of stuff that can be tricky. And telling reactive from neoplastic in lymphoid infiltrates in the skin, to me, is one of the most vexing and difficult and frustrating things, because it's really hard sometimes to be sure. All right. So now this is a patient that has multiple red papules that wax and wane over time. So same clinical story, but now microscopically, whoa. We got big ulceration with crust on the top, and then we have this very infiltrate that's top heavy like the last one, but way more dense. And even from low power, you can see these monster ugly cells, huge cells that are in there. And going close, it's like a sheet of the nastiest, ugliest, big nasty cells you can imagine. Mycosis everywhere. I mean, this has got to be evil, bad lymphoma, right? Well, the patient has multiple papules and they go away over time. So in that case, with that history, and of course, these are going to all be CD30 positive. So this would also be lymphomatoid papulosis. Again, it has to have that proper behavior. And sometimes at the beginning, we don't know how it's going to behave. So this is why we use CD30 positive T-cell lymphoproliferative disorder to encompass these things, because it often takes some follow-up to find out what it's actually going to be. All right, so these are sheets of ugly CD30 positive large atypical cells, and so that's the type C. Type B is a one that I personally, I don't know if I've ever seen a really good example. It's supposed to look like Mycosis fungoides microscopically and have some epidermotropic kind of pattern, but I've not seen a good example of that yet. I usually see either type A or type C in my practice. Okay. So now this patient has a single nodule that's ulcerated and red. It's been there 6 months. It's a huge mass, sheets of ugly cells. When we go closer, there they are. They look ugly and nasty, just like the last case. Of course, they're diffusely CD30 positive. So what's this? Well, this is going to be primary cutaneous anaplastic large cell lymphoma. It looks to me microscopically identical to LYP type C. The only way really to know, looking at them, is if over time you get multiple lesions that come and go. That's probably LYP type C. If it's solitary, probably primary cutaneous anaplastic large cell lymphoma, although sometimes they can get multiple lesions, sometimes they can regress on their own. It's a little complicated. And sometimes there's some molecular that can be helpful in sorting these out too, but we're not going to go into that in this talk. So the thing that's important, especially for pathologists watching this, is that the problematic thing is that there's another disease unrelated to this one that's also called anaplastic large cell lymphoma, and that's nodal or systemic type ALCL. And the problematic thing is they both are composed of large, ugly cells that are CD30 positive. So it seems like they would be the same thing, but they're not. The ones that are nodal usually are ALK1 positive. They have an ALK gene abnormalities, and they're going to be positive on ALK immunostain. In fact, that's what ALK stands for, Anaplastic Lymphoma Kinase, ALK. And ALK is positive in a variety of other things. In the skin, not very many things. Some of the things that you can see ALK in, just for if you're making a list to remember, epithelioid fibrous histiocytomas are ALK positive. Some spitzoid lesions are ALK positive, like Spitz nevus and sometimes Spitz melanoma. ALK is also positive sometimes in angiomatoid fibrous histiocytoma, which is a weird intermediate malignant potential tumor that is positive for ALK on immunohistochemistry, but is actually negative, I believe, for ALK fusions by molecular testing. And then also ALK can be positive in inflammatory myofibroblastic tumor, which is usually a thing that's seen in the viscera, the internal organ areas, and the retroperitoneum and stuff, but rarely can present in the skin. And I've got videos about some of those entities you can go and check out if you need more. These are all pretty rare esoteric things. Okay, so anyway, what I usually do in these cases is I will do the ALK. If the ALK is positive, then it's almost certain that they have systemic nodal ALCL that's secondarily spread to the skin. So the more frustrating problem comes up with the fact that not all systemic ALCL is ALK positive. There is a smaller subset that's ALK negative, and that subset tends to be more aggressive. So nodal ALCL that's ALK positive has a pretty good prognosis, actually, but the ALK negative form, the prognosis is worse and it's more aggressive. So if that spreads to the skin, it would look just like this. So these patients, you know, if they've got one lesion, I often want them to monitor for, does the patient have B symptoms? You know, maybe palpate and see if they have any enlarged nodes. It may not, different people have different views about how far to work these patients up, but working them up to make sure they don't have an internal lymphoma is not a bad idea, especially if they have any other symptoms to suggest that. So it's good to keep an eye on those patients. And again, you can ask your friendly local lymphoma expert for much more detailed guidance on this, but I'm just trying to teach you the morphology and how to approach these microscopically. So how I sign these out, and again, now I'm lucky I work with really awesome cutaneous Hemepath experts like Dr. Junkins Hopkins, so I can show her and get her guidance. But what I've done over time in the past is I put the line diagnosis as CD30 positive T-cell lymphoproliferative disorder. Comment that all of these things could look the same microscopically. LYP, primary cutaneous anaplastic large cell lymphoma, systemic nodal ALCL involving the skin, like if it's the ALK negative type, and even CD30 positive large cell transformation of Mycosis fungoides. And on a biopsy alone, it's essentially impossible to sort those out if you have a sheet of ugly CD30 positive cells, okay? You cannot look at that and say, oh, it's large cell MF. The only way you can have large cell MF is if the patient has like background regular MF or a history of MF, okay? So really all the clinical pieces have to be put together to sort it out. So this is the way I end up managing this. And if I have more information, then I can sometimes be more specific. It depends on the context of the individual case. And I think that's the end of that topic. Any questions about that?
Yes. I'm curious, for cases like the ALCL one you were talking about, do you normally put those recommendations for workup in your sign out, or is it expected that you do that?
Well, a lot of people have different views about how much a pathologist should say in their comment about what should be done clinically. So it depends on the situation. In general, I tend to, especially with this topic here, I do tend to say, like I've had times in the past, I used to take consults. I don't anymore in my job because it was just getting too busy, but I used to take consults. So sometimes I'd be getting it from someone, they had, very little clinical information. Sometimes it was coming from a non-dermatologist. So in those cases, I say, look, the patient needs to have a full body skin exam and they need to have additional workup done. So yeah, I personally feel comfortable putting those things in my report. And I've been doing that for 8 years now of recommending what should be done clinically. And I don't think I've ever had anyone come back and tell me, how dare you tell me what to do? Because most people are like, oh, thanks, you're making a weird diagnosis of something I've either never seen or rarely seen. and you're telling me what the next step is to do. So that often helps people because it saves them having to go look it up and figure out, what's the best thing to approach this. They've got like a next step, right? That's easily there. So, and especially when I sign out reports of like, because I also do bone and soft tissue pathology in addition to derm path. So when it's a sarcoma or something, in general, unless the person treating them is a orthopedic oncologist or otherwise a sarcoma expert, I have more familiarity with those diseases than the vast majority of doctors do. So I feel very comfortable saying this is the next steps that need to be done. And I feel like that to me, that's comfortable and it's good for patient care. But I also think that it's totally understandable that some pathologists are not comfortable doing that and just leave it up to the treating doc. So there's different styles and approaches. But personally, yeah, if I know something that could be useful to be done, and I feel that might help the patient and help my clinical colleagues to know how to best, next steps for the patient, I feel like why not share that information? Now, I sometimes I soften how I say it. Like these could be, if clinically indicated, I might do this and that. That way I'm not tying anyone's hands. But yeah, and it seems like people tend to at least tolerate it. Maybe some people don't like it, but no one's come back to complain to me that I can think of.
Yeah, it's great to know.
I have a question.
Yes.
So you mentioned the CD30 being a marker for the immunoblast, which, if I recall, I think that's like something that's implies like it's been activated antigen that's already like left the germinal center. Right? Does that imply a certain? Are these like derived from that lineage then, or do these CD30 positive lymphoproliferative disorders they can follow the CD30 like independently, and that's just like completely different?
That's a great question. I have no idea. I have only the very basic grasp of immunology that I've retained kind of a framework of from med school. The intricate details of just even normal, immunology or immune physiology are way over my head. And then the lymphomas, I think, become even more complicated because people do talk a lot about, if something comes from the germinal center or post-germinal center. But that stuff is beyond me. So I really don't know. That's a really great question. I suspect though that, because these are driven by, I don't know. I'll just say I don't know. Let me just be honest. So, but maybe that's a good question to ask someone who's really into skin lymphomas. Maybe they'll be able to help us sort this out.
Cool, thanks. Just wondering because I was wondering if it has any implications as far as like potentially management, treatment, that kind of.
Yeah, I don't know, and I don't know a lot actually about for LYP and ALCL. I don't know a ton about how it's treated. I know there are kind of some different approaches, and I think a lot of times they tend to be a bit conservative. But I have seen cases though where they were like large fungating mass, and it was problematic for the patient. But I don't really know the current best practices for treating those patients. And there are CD30 inhibiting drugs, like monoclonal antibodies. And I know that like at least for CD30 positive large cell MF, I know some of the derms I've worked with who specialized in lymphoma, they would use those drugs for treating that. But as far as if that's routinely used for like LYP or cutaneous ALCL, I'm not really sure how often those kind of drugs get used.
Cool, thanks.
Yeah, sure. Anything else? Okay, well, we'll march on then. Now, leukemia cutis, which is basically, I tend to use this term for some variation of acute myeloid leukemia in the skin. So, technically CLL, chronic lymphocytic leukemia involving the skin, would also be leukemia cutis, but I feel like that is a much different clinical situation and much different like behavior and prognosis. So I like to just call that CLL, SLL involving skin. And I feel like leukemia cutis to me, as I usually personally like to reserve it for like AML or some variation thereof involving the skin, relatively serious and oftentimes urgent diagnosis that needs to be dealt with expediently. So you could say, well, look, this looked a lot like that tumor stage MF. It's just blue cells filling the dermis. And that's true. So when you see blue cells filling the dermis, especially this pattern, this diffuse sheets with, I find this really helpful, some strands of the background reticular dermal collagen still intact. What this tells me is these cells are very loose and discohesive. They're not like nests of tumor cells that are, invading between and pushing stuff out of the way and making a bunch of reaction to it. These are cells that are just like kind of like a bag of loose cells poured into the dermis and filling up all the gaps, all the spaces. So it starts out sometimes it just subtly intercalate between the collagen bundles, and then as it gets more cellular, it kind of pushes the collagen out of the way, but you can still see some of that collagen framework left behind. So to me, that's very characteristic of hematopoietic malignancies in the skin. Leukemias and lymphomas do that. Particularly leukemia cutis does it, but also lymphomas can do that same thing. So I find when I see that pattern, low power, leukemia cutis, first thing that comes to my mind. But of course, a wide variety of other round blue cell malignancies, could potentially present like this too. So here's what I'm talking about. You can see the cells going between the collagen bundles. Now, if you pick out any one of these cells, they kind of have a little bit bean-shaped nucleus, if you can see that there. They got a little cytoplasm, a little bit like kind of histiocyte looking. Obviously, way too cellular, and there's mitotic activity in here. But individual cells kind of, to my eye, look like histiocytes. Now, the reason for that is that a lot of the times when you have acute myeloid leukemia involving the skin, it's usually one of the forms of acute myeloid leukemia that has some monocytic differentiation. Remember, monocytes are the hematopoietic lineage that macrophages and histiocytes are derived from. Those are cells that tend to go to the skin and home into the tissue, right? And so the immature forms of those, the leukemic forms that have some histiocyte-like or monocyte-like derivation, like acute myelomonocytic leukemia or acute monocytic leukemia, it's the monocyte forms of the immature cells that tend to be the ones that go to the skin. Even in patients that have myeloid and monocytic cells, one of my Hemepath friends, Dr. Jeanette Ramos, who I've done a video with about leukemias and other Hemepath things in the blood, for the pathologist watching this, I'll put a link down below. You'll probably find it very useful. She's a brilliant, amazing teacher, really wonderful. Probably a little bit less relevant to the dermatologist watching this. But in any case, she was the one who said that even in the patients that have both myeloid and monocytic types of blasts, it's the monocytic ones that tend to be the ones that go to the skin. So to me, I like that because that explains they look a lot histiocytic-like. So I think that's helpful. And they tend to stain with histiocyte-like markers. They can stain with CD4 and some of the other markers. One of the problems is that, in the bone marrow, blasts tend to stain with CD34 and CD117, or also known as c-KIT. But a lot of times when blasts get into the skin in leukemia, and maybe it's because they're more monocytic derivation, I don't know, this is a little bit beyond where my knowledge goes, they tend to not stain with those typical blast markers that are often used in the bone marrow as much. So the problem is that there's not one like perfect stain for leukemia cutis. So I often do kind of a panel of stains, including myeloperoxidase. Try to keep in mind that lymphomas can sometimes look like this. So if I'm not sure what it is, I might include a CD3 and a CD20 to cover B and T cells, a myeloperoxidase to try to recognize some blastic derivation. And then also there is a really rare thing called blastic plasmacytoid dendritic cell neoplasm, which to my eye looks, I don't know how to tell it apart. I've rarely seen it, but it looks to me just like leukemia cutis, and it'll stain kind of like, except it stains also with CD56, I believe, and also plasmacytoid dendritic cell marker CD123. Really esoteric stuff. It's very aggressive tumor and rare, and I think easy to miss if you're not thinking of it. So anyway, you can go and read up about that, about the staining panels. The big thing is if they don't know if the patient has leukemia, and I see this, they need to get a white count right away. Get a CBC, check what the peripheral smear looks like, because most of the time when patients have leukemia cutis and have AML, they either have known AML or they just recently diagnosed, or they're having a recurrence, something like that, okay? It's pretty rare, although very, very rarely it can be the presenting sign that they show up with leukemia cutis before they have obvious leukemic involvement of the blood. And extremely rarely you can have leukemia cutis without actual circulating leukemia. You can have leukemia cutis, or you can have AML show up as a mass in other organ systems actually without circulating leukemia. And in fact, a friend of mine, back when I was a residency, had that happen, had an internal mass that it kind of coincidentally discovered. They had some kind of vague symptoms, and it was AML, and they didn't have any involvement of elsewhere in the body, which is very strange and weird. So that's one thing to keep in mind. So if I have any doubt about AML or leukemia, the main thing, I want to check the history. If they don't have a history, then I want to have them get workup, get a CBC, find out, okay? Especially if I'm uncertain. In this case, this looks like slam dunk, and these are the atypia of the cells close up here, just to show you. Again, they kind of look histiocytoid, but very atypical. Now, though, what about this? This is a very, very subtle example of leukemia cutis. In this case, actually was fatal. This was acute myelomonocytic leukemia. I mean, man, that could be like inflammatory at first glance. The thing is when you look closer from lower power, I think I didn't put the low power picture in here, but from low power, this would just look kind of a little bit like perivascular lymphocytes and maybe some scattered, EOs in here. But at higher look, the cells are a bit bigger, a bit more atypical than lymphocytes. And again, if you struggle with that and you're starting out, it is subtle. And that's why I show this, because it can be very subtle sometimes. So when I see larger cells in the dermis, I always want to know what those are. There's plenty of benign reasons to have scattered large cells, or even some larger cells around vessels. You can have histiocytes, you can have reactive lymphocytes, immunoblasts, the CD30 positive reactive T and B cells like I mentioned earlier. Sometimes you can have large scattered cells in the dermis that are reactive fibroblasts or myofibroblasts, like in the setting of granulation tissue and other reactive things. So there's a variety of benign things, but when I see big cells that are a little atypical in the dermis, I generally like to find out what they are. So I'll sometimes consider doing a CD68 and maybe a smooth muscle actin if I'm thinking of myofibroblasts. Obviously, I wouldn't think of that here, but and a CD30, and I may, if I have any doubt, throw on some leukemic markers like myeloperoxidase. Okay, so it can be very subtle, and in these very subtle cases, this often means I need to talk to the dermatologist and say, hey, I'm a little worried that just maybe this could be subtle leukemia cutis. Could you get a CBC and follow the patient closely? And there's another topic we're not going to delve into today, but there's a variant of Sweet syndrome. Sweet syndrome, as you guys know, is neutrophils filling the dermis, but there's a variant called histiocytoid Sweet syndrome. And my understanding of that disease is that basically it's like Sweets, but instead of totally well-developed neutrophils, the neutrophils are a little bit more left-shifted. They look a little bit more like bands. And because of that, they can kind of resemble, myeloid cells are what, the precursor cell that eventually becomes neutrophils and a lot of the other white blood cells, right? So an immature neutrophil is a myeloid cell, basically, right? So there's a spectrum of features there that they can overlap, and those will stain with myeloperoxidase, and they look a fair bit like leukemic blasts sometimes, usually not as atypical, but so when I think something's histiocytoid Sweets, I usually want them to follow the patient closely, get a CBC, keep a very close eye on them, make sure they respond to therapy like you would expect Sweets to, and if not, go back and biopsy again, just because I'm always very worried, because I think histiocytoid Sweets and leukemia cutis can sometimes be very difficult to tell apart, if not impossible, microscopically. So anyway, just to throw that out there, it's an important thing to keep in mind because you don't want to overcall it, but definitely it's one of those things that's very challenging. So I'm certainly not an expert on that, but you can go read some more about histiocytoid Sweets because it can be pretty scary looking. All right, and here's a closer look at these myeloid blasts in this case of AML. Okay, any questions about AML before we move on? Okay. Now, juvenile xanthogranuloma, also known as solitary xanthogranuloma or just xanthogranuloma, whatever you like, because they often occur in kids, but adults can get them too, and they're not always solitary. They can be multiple sometimes. So the classic is that they're usually in little kids. About a third of them are present at birth. They're usually in kids under a year old, but I see them in adults on a regular basis, okay? And often on the head and neck, and tend to have kind of a reddish brown to yellow color to them, okay? Because of that kind of lipid content. So this is a nice example, like a diffuse dermal replacement, and you can tell from low power these are probably going to be histiocytes, or a lot of histiocytes, because of how pale it is, right? A dense lymphocyte infiltrate is going to be blue, because lymphocytes have a lot of nucleus and not much cytoplasm. But here, when you see a lot of pale pink or gray from low power, think about something histiocyte rich. And of course, the classic thing that you want to see are these beautiful Teuton giant cells, and usually eosinophils will be present too. So Teuton giant cells have a ring of nuclei and have a smooth kind of creamy candy filling, or and a crunchy, crispy, foamy shell around the outside is the way. I think Ron Rapini said that once, and I loved it and I stole it from him. So I'm pretty sure I heard him say that. I hope I'm not taking his name in vain. But in any case, one of my great mentors who I'm a huge fan of. I love Ron Rapini, just such a great derm path and a wonderful teacher. So anyway, the Teuton giant cells are usually present, but the thing is that sometimes they're abundant and sometimes they're very sparse or even absent. The other thing is that when a Teuton giant cell looks like this, no problem, right? You got this. But look, this is a Teuton giant cell also. It's just cut kind of funny and it doesn't have a full ring of nucleus. This probably is too. We're just seeing it only like one little snip. We're like cutting across it kind of like that. And then here's one that's kind of incomplete. And look at this down here. Here's one too. So it's worth, when you see a nice JXG, spend some time learning about the different ways that two-ton giant cells can look when they're not perfect. Because when they're perfect, no problem. But when they're imperfect, then sometimes you can struggle to recognize them. And also remember that two-ton giant cells can be present in a lot of other things, including, say, dermatofibromas and other things like that, okay? So that's nice two-ton giant cells. Here's another one. And also all the EOs came out to party with the two-ton giant cell here. That's what you want to see, right? But not every case looks like that, okay? There's a wide range of features in Juvenile Xanthogranuloma. Sometimes they're classic like this. Other times, not so much, okay? Sometimes they can be very fibrotic and spindled, and they can look a lot like dermatofibroma. Sometimes they can have just sheets of histiocytes and not have any two-tons. Sometimes they have tons of EOs, sometimes very few or none. And those cases can be a little bit more challenging to diagnose. So here's an example from low power. This is a little papule on the face of a kid, and it has a little infiltrate here. And looking closer, man, that reminds me a lot, or at least it did at the time, of mastocytosis. It looks a lot like mastocytosis, which we'll talk about in a minute. And it's kind of filling up the papillary dermis, but not involving the epidermis over top. And the cells kind of have an almost grainy look, grainy to bubbly maybe. Sometimes it's hard to tell. And there are EOs here, which there can be in mast cell disease. But when I did a stain, this was negative for mast cell markers like CD117 and tryptase, and positive for, I think, CD68 or something. So this is what is when JXG is early. An early JXG, when it's first kind of developing, tends to be mononuclear histiocytes with a little bit of foamy cytoplasm, but tends to not have well-developed two-ton giant cells yet, or some of the other features. And because of that, the kind of uniformity of it can make it look a lot like a mastocytoma, I think. Now, in contrast, this is an example of a mastocytoma, or urticaria pigmentosa form of mastocytosis could look like this. Depends on the clinical, but you can see kind of similar. These do have the cytoplasm texture is different. These are really kind of a finely granular cytoplasm because of the little mast cell granules that can contain histamine and tryptase. But I think I said that wrong. Histamine and what's the other thing in the mast cell granules? I'm blanking. The one that vasodilate. I don't know. In any case, I'll come back later and edit it out, or I'll just leave it in there and people can realize that I forget stuff every day. So in any case, though, you can even see a couple little EOs in there, okay? But look, there is a little difference, but they look kind of similar. I thought so. Somehow this one is a little bit pixelated, but okay. Reticulohistiocytoma is much less common than xanthogranuloma, but I like to include it right here because it looks a lot like xanthogranuloma. So there are two forms. The solitary form, which sometimes people call solitary epithelioid histiocytoma, and it's kind of similar, brownish, reddish yellow papule, and it's solitary and it's a benign thing, okay? Then there is in my experience, much less common multicentric form of reticulohistiocytosis that we call it. And these patients often have multiple lesions, tend to be on the fingers, sometimes the mucosa, and they have some significant serious systemic problems like destructive arthritis, autoimmune diseases, sometimes internal malignancy, lipid abnormalities, etc. So those patients with multiple lesions, they actually need to get some additional workup and could potentially have problems. The solitary ones are not problematic. Now, this is what they look like. They tend to have some similarity, I think, with xanthogranuloma. The difference is the cells are much larger and really epithelioid. They have a ton of dense pink cytoplasm. And the nuclei can look kind of weird and wild. And I would not blame you for looking at this and thinking, gosh, could that be like a carcinoma or epithelioid sarcoma, something bad? So, if you want to do a keratin or a SOX10 to make sure it's not melanocytic or epithelial, that I would not fault someone for that. They also tend to have some background inflammatory cells, including EOs. Sometimes they can have foamy cells and two-tons. So they do, even though I think they're probably two separate things, like etiologically, I think that microscopically, they really have a spectrum of morphologic features that overlap. The thing I really like to see is the big epithelioid cells that have dense cytoplasm to them, okay? When I see those, that's what makes me call something a reticulohistiocytoma. If I really see few or none of those, and I see two-ton and a lot of two-tons and EOs, then I tend to call it xanthogranuloma, okay? And oftentimes, the cytoplasm of these big, dense pink histiocytes has a kind of two toned, not to be confused with Teutons, but a double tone, let's say that way, color. They have a kind of a more purpley or lavender area in the middle, and then a more pale pink towards the outside. See it there? Here's some here. I tried to capture it. It's a little hard to get a good picture of, but I think it's a kind of distinct thing. Once you recognize it, it's a very distinct look that these histiocytes have, okay? Oh, here, that's a better picture of it. You can see the darker purple in the middle. And I suspect this is just a matter of how the cytoplasm is arranged. I'm not really sure, though. Okay. Langerhans cell histiocytosis is a really important disease because some of these patients have systemic involvement, depends on the setting. It's often in infants, rarely, though, it can happen in adults. And the different forms of it, of course, which we all learn in med school, but oftentimes when we see it in the setting of dermatology and dermpath, it's in babies that have multiple reddish-brown papules that are either on the scalp or in the groin, particularly like in the inguinal crease, right? And that's kind of how one of the tricks to tell it apart from, diaper dermatitis, right, is that it's not in the central area, it's actually out at the crease on the edge. And then sometimes people have bone involvement, lung involvement, or other systemic involvement. And it can be a very serious disease depending on the extent of involvement. Okay? The thing to remember about Langerhans histiocytosis is you have histiocytes, the Langerhans cells, which are basically like a variation of, I guess, or a relative of histiocytes. Maybe I should have reworded that. But they look histiocytoid. They fill the papillary dermis like we saw in a couple of the diseases earlier, but also they infiltrate the epidermis. And remember, where do Langerhans cells live? They live normally in the mid layer of the spinous layer of the epidermis, right? They're as kind of sentinels scouting for antigens that are breaking through the skin, and then they eat that up and process it and take it back to a lymph node and activate an immune response. That's the level of immunology I know. Very simple bedtime story immunology, okay? Not real deep science immunology. But because of that, whatever marker it is, whatever surface molecule these cells have that allow them to cross the basement membrane and get into the epidermis, they have that in normal Langerhans cells. So of course, Langerhans histiocytosis, in the proliferative form of Langerhans cells, they also have the ability to get into the epidermis, and they often do. So you don't want to confuse this with the pagetoid spread of melanoma. You don't want to confuse this with epidermotropism in Mycosis fungoides. I certainly have seen times where a case of Langerhans cell made me think of those things. And also, guess what? They're S100 positive. So you could, if you made a mistake and you did S100 and thought, oh, it's S100 positive, could be melanocytes. I mean, usually you wouldn't make that mistake, but do keep in mind that occasionally it could get confused. So the infiltration of the epidermis is usually present. I have seen times that Langerhans cell histiocytosis did not have that, but it's usually there. Okay, and the two things Doug Parker, my fellowship director, liked to talk about, there are two main diseases that fill the papillary dermis with cells, and that's Langerhans cell and mastocytosis. And the difference, he said, is that mastocytosis respect the boundary of the basement membrane. They do not cross the border into the epidermis, whereas Langerhans cells do so with impunity. They just get all up in the epidermis, no problem. So that can be helpful. And here's an example, okay? You got Langerhans cells clustered up there, and you can barely even tell where the dermal epidermal junction is. I guess it's like right here. And there's lots of scattered Langerhans cells in the epidermis here. Now, sometimes it can be a little hard in more subtle cases to tell if you just have a really robust Langerhans cell, a Langerhans cell rich example of sponge derm or contact or something, or do you have Langerhans histiocytosis? And I have occasionally in young kids or in times where there's a clinical concern and the microscopic is kind of iffy, said, well, there's increased Langerhans cells here, but it's not really classic for LCH, but it's enough that it's worth keeping an eye on the patient and rebiopsying them if the process continues. Thankfully, I've not had to do that often, but it's certainly something that if you think about it, check the clinical, and if there's any potential it could be, at least have it there on the dermatologist's radar so they can follow the patient and make sure that it does not progress, or they can get additional workup. And they have the classic grooved or bean-shaped nuclei, okay, that we learn about. And here's a CD1A immunostain, which is strongly positive. And they're also positive for a molecule called Langerhans, and then S100 as well. And I'll just mention this here. I have some cases, but I don't have any pictures taken to show you. There's this very weird rare disease called indeterminate dendritic cell tumor or indeterminate cell histiocytosis, which the simple way to think of it is basically it looks like Langerhans histiocytosis, but it lacks if you do electron microscopy, which most people don't have easy access to, it lacks Bierbeck granules, which are the classic ultrastructural finding of true Langerhans cells. But otherwise, they look and stain like it. The one thing that we do have is this molecule Langerin, which I think is a CD207, I believe. I always have trouble remembering that for some reason. But in any case, Langerin seems to go hand in hand with the presence of Bierbeck granules, so we kind of can use that immunostain as a surrogate marker instead of doing electron microscopy. If Langerin's negative in those cells and it looks like LCH otherwise, then it's probably this indeterminate dendritic cell tumor. And they can present in adults as one or multiple papules on the skin. I've seen a few times where it was like a solitary papule in an old person, and it microscopically looked just like Langerhans histiocytosis. In those cases, I send out and get the Langerin stain, and if it's negative, I call it this. There have been some that have had aggressive behavior, but a lot of times they have indolent. It's kind of variable behavior, widely variable, and we don't really know how to predict it, is what my last reading on it in the WHO said. Okay, mastocytosis. I already showed you, so we'll just kind of go through it. Here's another example of filling the papillary dermis, but not involving the epidermis usually, or very minimal involvement. And again, CD117 or c-KIT is another name for that. Will stain these strongly, as will mast cell tryptase. And you can use some other special stains. Do remember that other things stain with CD117, particularly melanocytes. Okay, so if you see cells in the epidermis that are CD117 positive, they are probably melanocytes. And there's a closer view. You can have EOs in it. And there's a picture. So see, those might be a couple melanocytes, or maybe there are a few rogue mast cells that are getting in the epidermis even though they're not supposed to. Kind of violates the rule I just taught you, but you can see predominantly these are confined to the dermis. All right. Rosai-Dorfman disease, an important one to know, also known by the name of sinus histiocytosis with massive lymphadenopathy when it occurs in lymph nodes. Obviously, that name doesn't really make sense when it occurs in soft tissue, which is the main time that I encounter it. All right. So what you see from low power, my former fellow, Dr. Betsy Uhlenhake, she liked to say pink and blue, baby. So there's a shout out for Betsy, who's an awesome fellow. That low power, you have pink and blue areas. You have these sheets of pale pink or even gray, and those are the Rosai-Dorfman histiocytes. And then these punctuated by nodules of blue, and those are lymphocytes and plasma cells making aggregates and sometimes even germinal centers. So at low power, this, I'm like, Rosai-Dorfman is the first thought on my mind when I see this. Most cases I've seen are nodules in the subcutis, often on the flank of a 20-year-old woman, a young adult. They often get misdiagnosed clinically as cyst, just like any nodule in the subcutis would look like. Everything's a cyst until it's not a cyst, until you biopsy it and realize it's DFSP or something else. So I've got a whole box of things that are not a cyst that were thought to be cysts clinically. So in any case, that's the classic low power view. And then when you go to higher power, what I want to find is these big, huge histiocytes with a ton of pale cytoplasm and large nuclei with pale chromatin and prominent central nucleoli. And look, there's usually a lot of plasma cells hanging out around vessels. There's usually a lot of lymphocytes like I showed you from low power. That's the nuclear feature I want to see in Rosai-Dorfman disease. They have a very distinct appearance, their nuclei do, and the cytoplasm, they all like kind of blend together and make almost a syncytium. You can't see where one histiocyte ends and the next begins. And there's a plasma cell up there. See, it's pale perinuclear Hoff, and it's kind of clock face chromatin or chocolate chip cookie chromatin, if you like, little blotches of dark purple on the nucleus. All right, so that is Rosai-Dorfman. So that's what I want to see. Now you guys are like, well, but what about imperipolesis? Because that's the buzzword. But I feel like this is what I really want to be sure the diagnosis. Imperipolesis is just the icing on the cake. That's great imperipolesis. They're lymphocytes or plasma cells or other white blood cells or even sometimes red cells inside little vacuoles in the cytoplasm of the histiocytes. So the thing is it takes forever to hunt around a case to find a picture this good to put into a talk or a book. Most cases do not have really perfect imperipolesis in my experience. So the thing is that when we go back here, look, there's imperipolesis on this slide. That, everything you see here is cytoplasm, basically. It's a whole sea of histiocyte cytoplasm. So all of the white blood cells in here are sitting inside the cytoplasm of the histiocytes. But that doesn't look pretty like the pictures that we put in books, right? So that's the problem with imperipolesis. It's great when you see it, but you're going to spend forever hunting around for it, and you really don't need it, in my opinion, to make the diagnosis. Also, other things can have imperipolesis. Juvenile Xanthogranuloma does sometimes. I've seen sarcomas and other things that have little white blood cells in their cytoplasm. So that's important. S100 is going to be positive usually in Rosai-Dorfman disease. The histiocytes usually are strongly S100 positive in both their nucleus and their cytoplasm. And S100 will help highlight the vacuoles where the peripoiesis is, because it shows that there's a little empty space there and that the white blood cells are sitting in that space. So that can be helpful to do sometimes. Now, I'm going to finish up with a bonus case, and then we'll have plenty of time for questions. This is just an unbelievable case. And I don't expect anyone to know this because I've only seen this twice in my career. An old man with a skin nodule on the leg. Big diffuse sheet. Sorry for the folds and cracks, but sometimes it happens. And going closer, there's kind of sheets of pale histiocytes, aggregates of lymphocytes. I thought about Rosai-Dorfman disease when I first saw this, actually. I thought it was kind of pink and blue. For me, Rosai-Dorfman, most of the cases I've seen are subcutaneous, not dermal, but it can occur in the dermis. But I feel like I much more often see Rosai-Dorfman as a subcutaneous mass and less often see it in the dermis personally. But this one really made me think of that. But as I looked around, I thought, what the heck? There's giant cells here. Like there were giant cells, and they're actually like granulomas, real granulomas. And in my experience, Rosai-Dorfman can have fibrosis, it can have variable amounts of inflammation, but I don't recall ever seeing like good, real granulomas in Rosai-Dorfman. So that made me think, that's strange. Here's some more areas. Look, I mean, those are nice kind of epithelioid to spindled histiocytes making aggregates, real granulomas there. But look, it looks like in peripoiesis. Oh my gosh, that looks so good, doesn't it? It's got plasma cells. It's got so many perfect vacuoles. It's a perfect picture of peripoiesis. But the nuclei of the histiocytes didn't look quite right to me. And the granulomas didn't make sense. I think I did an S100 and it just showed patchy, background dendritic cells and scattered Langerhans cells like you see in any sort of process in the skin that's inflamed. So I thought, well, this is weird. So I have to admit, I did kind of an embarrassing number of stains here trying to figure out what this was. And then I thought, plasma cells and granulomas, that always makes me think of something. Does anyone know what this is? And again, I can edit this out later. And I've already admitted to you that it took me a while to figure this out. And then finally, once I thought of what stain I needed, I was like, oh my gosh, I can't believe it. I don't expect that any of you have probably ever even seen this before, but any takers, any ideas?
I was going to ask if you had done a fight stain. Okay.
Oh, well, you totally were asking the right thing. Yes.
I was wondering about an atypical mycobacteria.
That's exactly what it is. Good job. Wow, that's fantastic. Yes, I did a fight stain eventually. Finally occurred to me the granulomas, thankfully, were what clued me in. And they surprisingly not very, I mean, I had to hunt around to find them, but they were very real. And they're little clusters, almost like a little globus, like you'd see in leprosy. I don't think this is leprosy, though, solitary lesion.
Mean, leprosy probably was first on my mind, but then I was wondering about mycobacterial, just infection.
Right. So if it were leprosy, what type of leprosy would you call this when leprosy makes a mass like this? Histoid leprosy. So histoid leprosy is basically like a leprosy pseudotumor. In this case, I think, based on the clinical situation, I think was probably, like you said, atypical mycobacteria. There's a solitary lesion, and usually leprosy is going to have multiple lesions, right? And in any case, this case, unfortunately, the PCR was attempted and was negative. But I was like, I don't care. That is definitely AFB in the middle of the cells there. So sometimes PCR can be false negative on mycobacteria, especially when they're pretty sparse. So, it's great when it's positive, when it's negative, though. So we never were able to figure out the species, but in my heart, I believe it was probably atypical mycobacteria. And this is basically what you would call a mycobacterial spindle cell pseudotumor. And the leprosy variant of this would be called histoid leprosy, which is a variant of lepromatous leprosy, at least to my knowledge. I've only actually seen one case of histoid leprosy, and I have a digital slide of that online and a video about it, I think. And I think I have a video about it. Maybe I don't remember. I have a slide of it at least. I'll put a link down below. So if you're watching this at home, I'll link to it below. And it's a pretty amazing example of histoid leprosy. So the idea is that sometimes people get mycobacterial infection and they get this really revved up histiocyte and fibroblast response to it. It induces this really robust response that produces kind of fibrosis and histiocytes, so much so that it makes a mass. So it is a pseudotumor. Okay, So this is the kind of information about it. It often is multiple and in immunosuppressed patients, but to my knowledge, this patient only had a solitary lesion, if I recall, and I wasn't aware of any immunosuppression other than the fact that they were an elderly person. And I do feel like when I see atypical mycobacteria in the skin in my practice, usually it's either granulomatous or kind of abscess-like inflammation, and it's usually in elderly patients on the extremities. So my thought over time, having seen a fair number of these, is that probably people get exposed environmentally. They got it through sticking, getting a thorn or some injury in the garden, or cut themselves when they were fishing or something years ago. And the mycobacteria just kind of smolder there. And then as they get older and their immune system diminishes with old age, as kind of happens in the immunoparesis that comes with old age, that then the organisms flare up. And most of the cases I've seen have been floridly positive for organisms. And the same goes true when I've seen leprosy in my former job in Arkansas. There are armadillos there, 9-banded armadillos, which carry leprosy in the wild. Some of them do. And most of the patients that I saw that had leprosy either directly contacted armadillos or were close by, like gardened in the same soil. And I suspect some of them got exposure years before. So again, I think they had it smoldering there. And then when they got elderly and their immune system diminished, then the organisms exploded. And most of those were lepromatous leprosy with just billions of organisms. And we wrote a paper about that. I'll link it below, about leprosy in Arkansas and our experience. And it was really fascinating that we did see some patients that did not directly touch armadillos, but still got leprosy. And we think it's because the leprae organisms can live in the soil. So inside soil-dwelling amoeba. So if you're real excited about that, I obviously like infectious diseases, so you can tell I'm excited about it. But if you want to go read more, I'll put down below the link to the paper, and you can go check it out. So in any case, mycobacterial pseudotumor, kind of analogous to histoid leprosy, and a really dramatic case. So when and I remember seeing a couple of these at meetings in the past and thinking, I will never recognize this in practice. So I'm proud of myself for getting at least this one. And there's another one that I recently showed in another meeting, which I'll have a video on online soon. So I'll have both of the cases I've seen available for review online. Hopefully I've not missed any other ones, but I do think sometimes it looks kind of like dermatofibroma. Some of the ones shown at meetings look kind of like a DF, but they had a lot of inflammation, or they were multiple lesions, or the patient was immune suppressed. So you kind of have to have a high index of suspicion. So when I see plasma cells and granulomas, I try to do bug stains usually. And now that I've seen these, I go looking for it when I see something that's kind of a weird fibrohistiocytic thing with some foamy cells and it doesn't quite fit. And I don't want to miss another one, so I want to make sure I get it. So I do my fight stain.
The other thing that I had on my differential was actually I've seen a granulomatous bee sting reaction.
Oh, really? Wow.
Yeah. And it was very lymphocytic. It was lymphohistiocytic like that.
That's amazing. So it's the same kind of process, right? Where it's a exuberant reactive process that produces all of these, the spindly stuff that's growing there, which is unusual, right? Usually we see a lot of inflammation without fibrohistiocytic response, but when we see that, it can really cause us to struggle and start thinking about tumors and stuff. So that's really fascinating about the bee sting. I'd love to see an example of that one day. So I think that's the end of just to point out that not all that in peripalysis is Rosai-Dorfman. I think Shakespeare wrote that. I just totally blatantly ripped that off from him and then made it about a nerdy pathology thing. I also like to say that not all that palisades is schwannoma, because lots of things can palisade. So those are my two Shakespeare rip-off quotes. And Rosai-Dorfman shouldn't have granulomas. I already harped on all of this. And like I said, I did a bunch of stains and then finally did the fight. And I thought, oh my gosh, I can't believe it. And this is the other case I had, which came in literally a month later from the same person who sent me. Both of these are consult cases from the same pathologist. And I thought they're going to think I'm crazy to make this ultra rare diagnosis twice in a month, or it was, I don't know, a few weeks, a month or two, I can't remember, but near each other, near in proximity of time. So this is the other case, which is absolutely much more dramatic on the stains. And again, I'll have pictures and whole slide images from that one available. And I'll put links to that down below once I release that, so you can go check it out if you're watching this online. Really unbelievable case. Wow. Still blows me away. And I think that's it, guys. That went a little over an hour, but hopefully that was at least some interesting basic Hemepath. That's about the level I can function at. When we start getting into all the real esoteric stains and stuff, I'm like, I need some help here. So